Hi, everybody. Welcome to the class. So today we are going to discuss the medical emergency, the second session, the second segment of that class, the entire power session that we decided. So we have decided to divide the medical emergencies into 3 sections. And during our first session last week, we did the allergies, the cardiovascular emergencies. And in today's class, I'm going to talk about the endocrinal emergencies, the methemoglobinemia, and the neurological emergencies, as well as the ocular emergencies as well. So, and we will keep the respiratory emergencies about the inhaled objects and the asthma attacks for our next week's session, the third part of the session. So I'm going to start it. Just give me a second. You guys can see my screen clearly? All right. So just to review and reiterate that we discussed the allergies and the cardiovascular, the myocardial ischemia, the coronary syndrome, and the drugs that you would provide, the identification, the signs and symptoms, and the cardiac arrest, and the basic syncope. Plus in allergies also, we started with the minor urticaria and then moved on to the more severe angioedema and progressing to anaphylaxis. So I want to make sure, and I want to ask everybody for the exam, you need to know word for word the therapeutic guideline management of all the emergencies for the urticaria. And always remember in the exam when they give you an questions and ask you the management, what would be the initial thing that you would do? Always remember that coming for the management part, they can give you various options which would apply to the management of that situation. And then you have to select the one based on whatever is given in the history, whatever has been already administered, and what you would do next. So the crucial point is everybody can mug up that you have to stop the dental treatment and then remove the allergen and give the oral antihistamine, or in the case of anaphylaxis, stop the treatment, remove the allergen, lie them flat, and then give the adrenaline injection. Everyone can memorize these steps. What is crucial is to know that when an exam, the question gets asked, and you will be provided all these steps in one of the options. Like all the options would have one or the other point. The crucial thing to know is that what has been already covered in the history and what should be the next step. This has also happened when you attempt my therapeutic guideline quizzes, when I've framed those questions and I've used and tricked you with words. Have you not been getting caught in the keywords like we have been emphasizing on? But when you attempt the quizzes on a weekly basis on the course, have you seen that? That you miss a keyword, you get trapped in a keyword, or you ignore a particular keyword, whether it's initial, what would you do next, right? And then the entire answer gets marked incorrectly. So what we are learning on the program or on the course is not just the concept, but also a crucial method to evaluate the keywords. Notice the keywords in the language. ADC exam not just examines you or tests you on the concepts, it also examines you and tests you on your language skills, right? How you interpret the information provided. Is that correct or not? And when you take the therapeutic guideline quizzes on the program, on every week when you take the 7 quizzes on TG that, and I received the feedback from you all that you had read those concepts, you knew that, but still you make mistakes on the TG quizzes, right? Is that correct? Have you yourself encountered it or not? So the reason behind it is what? That first of all, it's not easy to memorize all the concepts, and that is why the TG quizzes are there for you to take multiple attempts and get it absolutely memorized. So TG quizzes, first of all, you have to take 3 or 4 attempts. Does that make sense? If you are on the first attempt getting 95%, 100%, it's fine. But if you're getting 50%, you still need to take 2-3 more attempts till you get it 100% right. And on my TG quizzes, you know word for word each page from the beginning of the therapeutic guideline book till the last page. I have created questions for you. So if you practice those quizzes multiple times, it assures you will not forget all the valuable concepts that are given in therapeutic guideline, and it also gives you a practice that how you can be tricked in the exam when all the similar concepts and options are given to you, right? So again, reiterating the fact that everyone knows it's just one book, everyone knows it's all tables and it's all boxes. First of all, it's not easy to memorize. And even if you memorize, the keywords in the exam can totally trick you. So knowing the critical thinking skill and analyzing what needs to be applied, what answers should come, whether it's initial management, next step, right? Or the most crucial management, right? All those keywords that ADC throws at you, you need to get that curveball all the times, right? And that will happen again by therapeutic guideline quiz repetition. So a lot of you have been sending me scores these days on TG because I know you all are on the TG quiz phase now because your subject wise quizzes are over. So you're doing the TG quizzes weekly now, and you have been sending me your scores. And what I'm evaluating is that yes, some of you are at a very good spot, but some of you are still around 50 and 60%. That means that TG revisions and the quiz revision is absolutely required. So are we going to do that or not? Now, from this moment on, our emphasis should be to multiple times revise the therapeutic guidelines as the book, plus also from the classes, the TG classes that I've provided you, and also the TG quizzes. So you have all the tools available. You got to practice that. Okay. So let's start today with the endocrine emergencies, and we'll do the methemoglobinemia, neurological and ocular. They're very small, so not a lot of discussion required, very straightforward, but you should know the sequence of the steps. And also when in the exam it's asked and they give you that this has already been done. So you know that what comes next. That's why knowing the sequence is also crucial. So the first endocrinal emergencies that we may encounter in our dental practice is the diabetic related emergency, would be first hypoglycemia, and then we'll talk about hyperglycemia, right? So these are the two main emergencies related to endocrinal situations. And so first, let's do the hypoglycemic patient management. And you know that it can be life-threatening if it's not managed and identified immediately. Are you aware of that? That it can be immediately life-threatening. And in fact, a minor delay can even immediately lead to loss of consciousness and ultimately impending death, right? So that's why immediately identifying the symptoms and signs and knowing the patient's history when they have arrived at your practice is absolutely important, right? So as you see that the patient's losing his still conscious but started to, like, the sign and symptoms are showing, like there can be various signs like pale skin, sweating, right, palpitations, he could be anxious, slurred speech, confusion, right? These are all the signs and symptoms of hypoglycemia. So any patient with diabetes history and showing you these autonomic signs and symptoms, which could be from the skin turning pale, the sweating and shaking, palpitations, these are all autonomous nervous system related symptoms. Then can be the central nervous system related symptoms, which could be from the brain going hypoglycemic. That will give you the symptoms of hunger and the patient's confused and inappropriate behavior, and it could progress to loss of consciousness as well, right? And could ultimately also give you seizure as well. So all these signs and symptoms, you would start the management immediately. You will have to stop the dental treatment, right? And administer glucose immediately. So you have to keep it handy in your practice. And for the adult patient, how much is it required? 15 gram is required. Is that correct? And if glucose is not available, Then you will give maybe some other food or drink which has your, just a second, guys. Yes, fruit juice 150 ml. Guys, let me just take a short 5-minute break. Is there some emergency? Just give me a. All right. So can you see my screen now? Yeah, sorry about the pause. Yeah, could you see my screen now? The allergies and all that, the main themes. All right, let me reshare. Right. So we were talking about that when you do not have the glucose solution readily available, but we need to provide. So this can be a tricky question in the exam, right? Like they can give you, yeah, I had some bad case of food poisoning and I had to literally manage that. So the vomiting and nausea is really getting to me. So yeah, that's the reason I had to literally throw up. But yeah, it's the water and the situation right now that's I'm dealing with. So although I've been taking the medication for the nausea, but it's still not helping much. Thank you so much, Sumaya. No, I'm good. So I'm feeling much lighter. I had to throw up, but it's under control. Thank you. So you know, last week also during the advanced file classes, I had been dealing with the fever, but that's okay. I've been dealing with it, and it's gonna get better, I'm sure. That's okay. Thank you so much. Thank you so much, everyone. But you know, when the class is there, so I have to take it, and yes, I'll have to handle the health alongside as well. Thank you so much for your kind words and giving me that pause. It meant a lot. No, 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 absolutely not. Once it's all out of my system, so I'm feeling much lighter. But the nausea is really getting me. I think it's the water. So the change of water, maybe probably in the food as well. But it's all okay. Thank you. Thank you so much. And let's get back to the management of hypoglycemia. And we were talking about that sometimes in the questions that you could be given that you've already stopped the treatment, right? And then in the options again, you could be given the same thing that you have to first stop the dental treatment and then do it. And multiple options could be given with the variation. So you have to make sure to notice in the question, in the history, that what has already been done. And then the question says, what would you do next? So you have to remember the sequence as well. That's and glucose doses you have to memorize because the patient's age can be different. It could be a teenage patient, although that's rare that if you get a juvenile diabetic patient, but you should remember the doses. But usually you will get, and what you usually get asked in the exam are their adult patients. And that's why 15 gram of glucose has to be administered as an oral solution when they are conscious. So you must have done, we have done that in Odell case also, the emergency management of hypoglycemia. And remember, we did that the IV management as well, when the patient had lost the consciousness and we did the glucagon injection and everything, you remember? So now what you have to unlearn here, everyone, right? Yes, Sanajinal, you have to unlearn certain things. See, Odell is a great tool for us to evaluate and know the situation, but certain things, as I've already told you, that whenever there's controversy and we see different references presenting different facts, we got to do it and follow the therapeutic guidelines as our defining factor, right? So we'll definitely stick with TG. And that is why if the patient loses consciousness, and in the exam if it's given to you, patient has lost his consciousness, and you get the option of glucagon, or you get the option of IV glucose solution, and then you get the option of calling emergency and doing your basic life support, then no matter what your heart tells you, that ideally you know that the patient should be given glucagon and the IV glucose solution. But in Australia, they are not expecting you to keep it. And that is why the best answer would be to call the emergency immediately and start the basic life support. So does that make full sense to everyone if the question comes and it's a very highly likely question and a situation? So I'm giving you this absolutely crucial concept here so you don't make mistakes, and you should know that with multiple correct managements also, you got to choose what is most suited to the Australian Dental Council exam. Does that make full sense for now? So far so good. So hypoglycemia orally and conscious you will manage, but the moment the consciousness is lost, you will just stop the treatment and call emergency, and your start the basic life support if there is no consciousness, right? So in the oral situation as well, in the conscious patient situation as well, if the question gets asked, how many solution rounds will you do for a patient before you have to call medical services or emergencies or stuff like that? So yes, a very crucial question, Akis, because I hope you like this style that when we do these themes and power sessions, we do it in the form of how they can be even asked in the exam. Like I've given you therapeutic guideline quizzes. So when you remember and memorize and we do these classes together and we kind of focus on learning the management, I hope you like the style that we also maybe hypothetically devise a question and then see how it may be asked in the exam so that you remember from these discussions, right? So suppose the exam questions comes, Ria, tell me like how many times would you give it before, or how many times would you administer the solution before you have to call the medical services? It would be 3 times you could give them. And how much time would you give or wait? Absolutely correct, Arti. You didn't even let me complete the question. So that means you are on it, you're memorizing and you're learning. So the time that you will keep between the solutions should be 15 minutes at least to let the solution get absorbed in the body and the patient show some improvements and signs and symptoms. Is that correct? And what are the substitute food? After that, you have to give them a longer acting carbohydrate food as well. It could be a sandwich, it could be yogurt, dry fruit, something like that, so as to prevent the recurrence. Is that correct? ADC gives you all these questions. What would you give the patient later? It can give you candies, it can give you something like maybe the juice, and then gives you the longer acting carbohydrates, the complex carbohydrates. So the sandwiches and yogurt and fruit. So you know that candies and juices could be the part of the early management. Is that correct? Because jelly beans, fruit juices, these are your early management when you don't have direct glucose, because they are your sucrose only. They are not your complex carbs. They are not your longer acting carbs. Is that correct? So they are your immediate sucrose administration, whether it's form of jelly beans or in the form of sugar teaspoons or in the form of your juice boxes. Is that correct? All these are direct sugars, simpler sugars, quickly absorbed. They are exactly, Grishma. They are your initial management and substitute for the 15-gram direct glucose available. But if the question asks you what would you administer after, once the patient's symptoms have resolved and you have administered glucose, and then the options are given to you, Grishma, the candy, the juices, and the complex carbs, then your complex carbs, long acting carb would be the answer. So absolutely makes sense. All these pages, suppose like we prepare like that, all these crucial topics, if we prepare like this, how it can be asked in the question, there's no way you can make a mistake in the exam, and immediately the bulb will light up in your head and you will remember these concepts. So the symptoms, you all know what could be the presenting symptoms, right? And what are the possible causes that can lead to the hypoglycemic situations in exam in your patient in clinic? So it could be if they took maybe higher dose of insulin or their oral anti-diabetics. Is that correct? So either the sulfonylureas or whatever the drugs orally they are taking, or the insulin, if they by mistake administered higher doses, it would reduce the blood sugar level to an extent of hypoglycemic episode. Or they, if they took the medicine but they did not take the meal afterwards and remained in a persistent or a prolonged probably a fasting situation, right? And then if they consumed or intook some of the food, but it was not in a sufficient quantity. And then rigorous or prolonged exercises can also slowly burn out the sugars in the bloodstream and can then give you a delayed hypoglycemic effect. Is that correct? So all these are the possible causes. So if in the exam the question comes like, what are the possible causes that patient could have been, you would be able to identify the correct option if you correctly remember these four causes: prolonged exercising, insufficient meals, excessive dosage of the drugs, insulin or sulfonylureas, or completely forgetting or skipping the meals. These are the four important leading causes to lead to the hypoglycemia. Will you remember in the exam? So any options that are given to you, you would be able to identify the incorrect ones, and do not miss the keywords, even in the options. Okay? And then hyperglycemia, how are we going to identify it and then manage it? It is not a very, very commonly presenting emergency, and usually it's very rarely seen as an emergency. Sometimes when you still find some emergency symptoms, that would be because of the diabetic ketoacidosis, right? Or which is also known as hyperglycemic hyperosmolar state. So the hyperglycemia per se on its own does not lead to an emergency. It can be a persistent situation, and the blood sugar could be remaining at a higher level without any presenting symptom. But sometime it can establish into diabetic ketoacidosis, and that has symptoms, which is abdominal pain, nausea, vomiting, fatigue, shortness of breath, right? Is that correct or no? So these are the hyperglycemic. So gastric symptoms associated with the history. So what would be the common finding in the exam? What would you remarkably find in the history provided? A very high HbA1c. Would you find that in that history or no? In a situation like this, right? So you should know the effect and the cause. If you're getting a question where the symptoms are resembling abdominal signs and symptoms, right, and they're resembling diabetic ketoacidosis, we should immediately know that there is a cause for it, and we should identify it, and we would be provided an excessive HbA1c levels, 9%, 10%. Is that correct? So everything is interconnected. All the dots can be connected in the exam. And how I have been showing you the picture test, everything is there on the picture. Is that right? So your mind only needs to know the concept. The exam will provide you the tools to identify the answer. Is that correct or no? So HbA1c automatically would be higher for you to pinpoint the gastric symptoms to the diabetic ketoacidosis, right? And then in the next questions, they could ask what, so patient presented this sign and symptoms of nausea, abdominal pain. What do you think could be the cause of it? Hypoglycemia, hyperglycemia, diabetic ketoacidosis. So hyperglycemia directly is not causing all these symptoms, but that converting to diabetic ketoacidosis is causing that. So if both are given as separate options, hyperglycemia and DKE, diabetic ketoacidosis, you know precisely what to mark, because to narrow it down, it's a diabetic ketoacidosis that's causing those gastric symptoms, right? Hyperglycemia on its own per se is not leading to those symptoms. Is that correct? And your only management is you can't do anything medically speaking. So you just got to call the emergency and start the basic life support if required. That means when the patient loses consciousness. Is that correct? And what other history can also pinpoint if you get the same sign and symptoms other than hyperglycemia? The presence of the SGLT2 drug history in the provided history, right? Suppose, Ishani, you're not doing an extraction, right? Then you don't stop SGLT2. Remember, we've done that concept only when you're doing extractions, you got to stop them, right? But suppose it was maybe a periodontal appointment and the history provides you patient takes SGLT2. And then in the symptoms, they say an emergency situation developed and he shows all the abdominal signs. Then and the question asks, what is the causative factor? So the diabetic ketoacidosis, even with the controlled HbA1c, because of the use of this drug, you can develop DKA. That is another important point. So can that be asked as a question? So you got to notice, if HbA1c is given to you 7% and SGLT2 is patient is taking, and you get the emergency of abdominal cramps, vomiting, nausea, etc., then the question asks you, what is the etiology? Then the etiology again is DKA. But what is leading to DKA? If the next question asks, what caused the diabetic ketoacidosis? When you know that HbA1c is under control, then this drug is also causing to that. Does that make full sense for everyone? And would you remember this entire theme? There are two causes of diabetic ketoacidosis: SGLT2 drug and the hyperglycemic situation. In both the situations, the management is not going to change. You have to call the emergency and perform the basic life support if needed, which would be with the loss of consciousness. So would you remember hypoglycemia? What are the four situations that will cause it? What is the glucose strength that you will give? What is the later long-acting carb that you will give, right? And then in hyperglycemia, two leading underlying causes, hyperglycemia as well as SGLT2, even in controlled glycemic situation. Both can lead to diabetic ketoacidosis, which is in itself an emergency and which presents as your gastric symptoms. And calling the emergency and basic life support if needed is your management. Nothing else that you can do at that situation, speaking in the basis of providing any drug or any other changes in posture or stuff like that. Everyone gets it? So far, so good. Both hypo and hyper. Right. And the perfect method of relating it with the question so that you can directly learn the application of the concepts as well. Now, moving to the next one, which is methemoglobinemia. Well, let's talk about it. Right. So methemoglobinemia is a blood situation, right, where the blood oxygen carrying capacity is reduced. And when the blood is not carrying enough oxygen, what it will cause? The tissues would be deficient in oxygen, right? So basically, you're practically anemic at that situation. It's a hypoxic situation. The delivery of oxygen is compromised to the tissues. So what will it look? The skin doesn't have enough oxygen. The blood doesn't have enough oxygen. Yes, the blueness, the slate grayness of the skin will present. That's a distinct feature. Other than that, the brain will also be diffused with oxygen, right? So brain will also be hypoxic. So hypoxic brain gives you syncope-like symptoms, which is headache, lightheadedness, shortness of breath, fatigue, and tachycardia. Why tachycardia? It's a tachycardia in response, a vasovagal response to counteract the reduced perfusion of the tissue, Aarti, right? We have done this in the Odell cases as well. It's a reflex tachycardia, isn't it? Right? To increase the blood perfusion into the tissues. But the blood itself is lacking the oxygen, so it doesn't really help. So what will help? Imagine in that hypoxic situation, blood is not carrying, right, enough oxygen, even if there is sufficient, even if you have the capacity to breathe oxygen from the air normally. So what we'll have to do, you will have to hypersaturate your blood with the oxygen. So you will remember that ways, right? And that's why you will have to, your management of methemoglobinemia will include, again, stopping the treatment, calling emergency first before administering the drug here. You will have to remember this. Would you remember this? Stopping the treatment and then calling the emergency first and then giving the supplemental, because whatever drug management or oxygen management you're doing, you know that it will not be a long-term solution. So ambulance has to start running before you start giving oxygen. So in the exam, do not forget this sequence. In a lot of situations, in hypoglycemia, the drug is coming before the calling 000. Is that correct or no? Right? So in a lot of emergencies, you will have to remember where the calling 00 comes first, where the drug comes first, right? Is that correct or not? So in the aspirin, glyceryl trinitrate, is the calling coming first? Zara, right? That's a good point to remember or no? In syncope, in anaphylaxis, urticaria, in every life-threatening situation, drug came first and then the 00 came. But coming to methemoglobinemia, because no drug is life-saving in this situation, even the oxygen is not life-saving, right? RT, that's why methemoglobinemia, give both the options are given, supplemental oxygen and calling. So calling comes first before giving. Would you remember this is a very crucial nuance? These are nuances, little nuances that if you know them well, nobody can stop you in exam from getting the highest scores, because these nuances differentiate the A scores and the B scores and C and D. Do you think there is a drastic difference between these grades? I don't think so. What makes and what sets you apart and gives you the 4 A's is those little nuances, the little tricks that we discuss in the advanced file, that we discuss in these power sessions, that will you set you aside from the crowd. And do we want to set aside and do you want to be aside from the crowd or no? Because you answered me before I even asked and completed my question. But do we want to stand ahead? Do you want to stand aside and be the 4A? Yes, we will. And it's not a fad and it is not something unachievable, but it requires patience, persistence, and continuous learning that we are doing every week. Okay? And repetition. Don't forget that. Without watching the classes again. Because in the class, I give you 100 concepts. Do you think by watching my class just once, you can memorize all the 100 nuances that I give you? All my nuances are power packed in those advanced file classes. And unless you watch it 2-3 times, you are going to all drip it down by the day of the exam. Everything is going to drip down. And you will only remember what an average student can if you're only doing it once. But are we amongst the averages? Are we amongst those who just do things once and don't care about them the next? No. We repeat, we revise, we review, so that we pay attention to those little tiniest details in the exam and get them straight on the bullseye. That is our purpose, and that's how we are preparing. So these on the TG classes as well, if you have watched my TG classes, I have highlighted all these nuances for you, have I not? In the therapeutic guideline classes, when we have in-depth discussed all the concepts, I have highlighted and emphasized and brought to your notice all these minutest nuances that you require for the exam, right? So I am providing you with all the tools. All I require from you is, when I am meeting you halfway, you meet me halfway by providing your dedication and repetition. You do the hard work by just watching it, revising it over and over. Can you provide me that? Right? Zara, you can join our crash course and all the TG quizzes would be included in that, right? So all the pages of therapeutic guidelines, all the chapters are in the form of questions that can get directly asked in the exam. So, and we have a promotion going on, so you can message me on my WhatsApp later. Now, everyone understood methemoglobinemia, what's going on in the body, what you're going to do, and what are you going to do first and then next. Crystal clear for everyone, right? Let's talk about neurological then. The neurological emergencies, the fifth on the list. So what can neurological emergencies look like? They can look like stroke, they can look like seizures, right? And they can look like your temporary paralysis. Is that correct or not? These are the nerves related neurological ones. And stroke we talked about in the last class also. I explained the difference between the stroke and the myocardial ischemia, myocardial infarct. Is that clear for everyone from the last session? No confusions, crystal clear, right? Distant difference between the angina, then the coronary artery syndrome, the severe form, and then it progressing to myocardial infarct, myocardial ischemia, and the clot going into the brain, then causing the stroke. So, stroke is a medical emergency. Recognizing the signs of stroke early are absolutely mandated to save the patient's life. Is that correct or not? Because it can lead to permanent brain damage if you don't identify it immediately, right? So the basic telltale signs of a stroke are there can be the paralysis of the facial muscle or your motor muscles in your limbs, or the speech can be slurred, and crucially, critically handling it well in time. So the FAST test, face, arm, speech, time. Is that correct? Face, arms, speech, time. So once you have identified the sign and symptoms, suppose an exam in the history, they give you the patient has slurred speech, and you think that his face is droopy, lips are droopy, and no history of diabetes. So what are we going to think? You have not maybe administered the LA also yet, right? So if there is no history of diabetes and insulin, and you get the slurred speech and the droopy face, so droopy face, any muscular involvement means the neurological, because the hypoglycemia is only giving you cerebral symptoms, right? The confusion, the slurred speech, inappropriate behavior, all the brain related uh, behavioral changes. But the facial muscles or the arm muscles involved. So the slurred speech, muscularly involved means the nerves are getting affected. So it is stroke. So how can you easily differentiate between stroke and hypoglycemic slurred speech and confusion? By the lack of the diabetic history, right? Now, the management would be again stopping the treatment, and stroke also is not having any life saving drug. Anaphylaxis, coronary artery syndrome, urticaria. Every situation, every emergency had a life saving drug. Yes or no? And reversing it. Hypoglycemia. If life-saving drug, right? Glucose is a life-saving situation at that point. So all the emergencies which have the life-saving drugs or solutions present, there you will delay calling the emergencies after administering life-saving drug. But in stroke, but in methemoglobinemia, right? Or in emergency seizures, status epilepticus, all this, none of the life-saving drugs is present. So in that situation, you will call 000 first. Now I'm absolutely sure none of you present here will ever forget this. What comes first, calling the emergency or giving the drug in any emergency situation now, right? I'm sure none of you would ever forget it now. Even in asthma, your puffs, your salbutamols, right? They are life-saving situations. That is why calling 00 is later before giving the life-saving drug. So you will always remember like this now. So no drug for stroke. That is why stop the treatment, call 000, and then just monitor the patient. You may start giving the oxygen as well and make sure that the patient's breathing. But the moment you see the breathing has stopped, then you have to start the BLS. Is that correct or not? Mostly monitoring the vitals, monitoring the airway, and giving the oxygen is best you can do. That's why calling the 000 first is important. Maintain the vitals in case any of the vitals is lost. If the pulse is lost or if the blood pressure goes too far below, or if the airway stops, start BLS, right? Basic life support includes two things: maintaining the airway and getting the blood pumping. Is that correct? It's a cardiopulmonary resuscitation. You're focusing on two major systems, cardiac system and pulmonary system. So any vital drops, pulse goes or breathing goes, you have to start. Even if one of them goes, you have to start. Is that correct? We have done all these details of BLS and everything in our 1,000 classes. So I'm assuming you're all aware of all these basics concepts for right now. I mean, so far you've covered all the 1,000 classes, so it's all done. So by now, those concepts should be crystal clear. This is how you manage the stroke, right? And if you suspect stroke, you will not give aspirin. So if any of the options gives you, call 000, maintain the vitals and give aspirin. In the case of stroke, slurred speech, pain in chest, absolutely go ahead, give the aspirin. But slurred speech, will you ever give aspirin? Right? Because if it's hemorrhagic, if it's because of the bleeding, then aspirin is going to increase that hemorrhage. Is it or not? Because only ischemic one, which is because of the clot, can be handled by aspirin. And the doctors will first, medical specialists will first delineate that, narrow that down. And only then they are going to administer either aspirin, or if it's hemorrhage, then they will handle the bleeding. But if you give aspirin and if the cause was hemorrhagic, you're making the patient's situation even worse. Is that right or no? Now, seizures, if the exam question comes, what are the causes of seizures? Let's talk about what are the causes of seizures. Epilepsy, straightforward. Syncope, if worsens and persistent diffused hypoxia. Syncope can also progress to seizure because of brain not getting enough oxygen can also cause seizures. That is why hypoglycemia can also turn to a seizure. Stroke can also cause anything that affects brain directly, either epilepsy or syncope, hypoglycemia, and stroke, or any other cerebral hypoxic condition can all manifest itself as seizure. Is that correct or not? And also in very young children, when the body size is too low, too small, and a very high grade fever, that can also cause seizures. Right? Excessive temperature, increase of the brain can also lead to that, right? So how would you identify the patient is undergoing a seizure? He would have jerky movements. That's the number one sign. Like they jerk their arms and heads and legs and limbs and everything. Is that correct? And suddenly there's tightness of their entire body and limbs, stiffness and jerk movements, right? So that's the predominant identifying feature. And if seizures are coming, patients resumes and gets normal and then again gets a repeated seizure, multiple seizure would be status epilepticus. In all the management of seizures, before you call 000, only the first 00 should be when the repeated seizures happen. So anytime in the exam question, repeated seizure happen, immediately tell me what will you do. You will identify it as status epilepticus and call 000. Understood? Exactly in exam, if the history writes, multiple episodes of seizure happen, one after the other, immediately choose your answer, call 000. But if it's a single seizure, either going on, so while it is going on, would you put anything in the patient's mouth, first of all? Nothing. Take out everything that's in the patient's mouth, stop the treatment. You're going to take out everything from their mouth and put them on floor so that they don't fall. Is that correct or not? And then you will also rather put them on the side so that if anything is in their mouth at all, the vomitus or anything, they don't aspirate it. And don't put anything in their mouth, even the vacuum, right? The suction, nothing. High vac suction, you won't. Only after the seizure has stopped. And then you check the patient's consciousness, check their airway. ABC is always to be checked. Blood pressure, airway, everything, right? Vitals should be tested. Consciousness and everything to determine whether they need BLS or not. Is that correct? So putting the patient down on the floor, making sure you've stopped the treatment, taken out everything from the patient's mouth, put them on the side and wait for them to relax and calm down and the seizure to stop, right? And then if you think it's status epilepticus, any repetition of the seizure, immediately call 000. And then absolutely you have to send the patient for the medical review also, even if it was a single episode. And would you send those patients alone home, or would you make sure that because after the seizure has ended, the patient's body has relaxed and again the fit happens. Again, the rigidity happens, that repetition, right? Or if they lose consciousness, immediately arrange for ambulance. Right? Zenny? Repeat seizure would be after the patient's body is relaxed and the seizure has ended. Again, the rigidity, again, the jerky movements happen. Or they lose their consciousness. Does that make sense? 2 episodes, right? 2 distinct episodes in between having a normal relaxed position of the patient, right? Now, the temporary paralysis of the periocular muscle is also one of the neurological emergency that can happen, right? So what are we going to do with that? It can happen because of the 2 causes. One can be temporary. The paralysis of the periocular muscle is mostly temporary, right? And it happens because of the accidental injection of the local anesthesia in the parotid gland, right? Due to the aberrant nerve formation. It could be because of the maxillary anesthesia or because of the mandibular, both accidentally injecting into the parotid capsule and accidentally anesthetizing the facial nerve. Facial nerve is a motor nerve, not a sensory nerve. That is why the periocular muscles get involved. Is that correct or no? Facial nerve is a motor nerve, and if you accidentally anesthetize it, it would temporarily paralyze the muscle that it supplies, and it would be unilateral because you're injecting on one side. Is that correct or no? So how are you going to manage them? Well, you got to stop the treatment, stop administering the LA if you're still on the middle of it. And then you have to explain to the patient that it has happened and tell them that nothing is to be worried about. It is not severe, nothing is serious, and it is only temporary. And you will advise them not to excessively rub their eyes if they feel any numbness there. Otherwise, they can just mechanically traumatize and cause injuries in the eyes. Is that correct? And you don't want that. And then to protect the eye from any mechanical rubbing and injury or any redness, you will cover the eye for a while, and it mostly recovers within 1 hour. So you're giving that patch only for 1 hour, okay? Double patch. One patch folded and one patch over it. And then put the patient on the chair and under observation on your clinic only. You will not send them home, okay? Once they go home after the recovery of the muscles, then also you will follow up on them for the next 12 hours. Would you or would you not? No, they are just normal eye patches to protect the patient from touching the eye and rubbing it to avoid that awkward feeling, right? And then you keep a check on the patient even after they are home. If it's still not recovered within the 12 hours, then you will send them for the medical review to the hospital. All right? That is how we are managing it. All right. So I plan to do the ocular emergencies and the respiratory emergencies on the next class. I think we have enough material to review and revise today. The endocrinal, hypoglycemia, hyperglycemia, diabetic ketoacidosis coming from hyperglycemia or coming from SGLT2, then methemoglobinemia with the reduced oxygen carrying capacity of the blood, calling the emergency before starting the supplemental oxygen, right? How you'll identify the slate gray skin, and the cerebral symptoms will also present, the confusion and everything, because brain is not supplied with the oxygen. Then the neurological ones, which is stroke, which is seizures, and which is also temporary paralysis of the periocular muscle coming from the injection of local anesthesia into the seventh facial nerve, right? How to manage stroke. Absolutely, to remember to not give aspirin in stroke, because you cannot identify the nature of the stroke, whether it's because of the bleeding or the clot, because aspirin can worsen the bleeding and can lead to even more perfused hemorrhage because it will thin the blood. Yes. And then calling the 000s in the emergencies where life-saving drugs are not available and the hospital administration to the ER department is the only life-saving method. In that cases, we will choose calling the 000 first. So you also learned about that great distinction point between all the emergencies. Then seizures, how can they be one episode? How can they be repeated episode? Repeated episode means immediate 000. One episode, how are you not going to put in anything in the patient's mouth? Even if there's vomiting, turn them to side, right? Put them on the floor. Do not restrict them unless completely necessary if they are harming and injuring themselves. Is that correct or not? Am I giving you a good overview? Yes. All right. So I think that is enough for today's class for you all to review and revise. Thank you. Yes, I hope I feel better soon. And we are going to meet tomorrow for our advanced file. And this week we are having double advanced file class, as I announced on the WhatsApp group as well. I'm going to reiterate that on the group and just going to remind you guys for the second advanced file class this week. Thank you so much for your wishes. And thank you for bearing with that tiny bit of my own emergency. And yes, thank you. Thank you. It means a lot. Thank you so much for your kind wishes. Yes, I'm absolutely healthy. It's just that I'm unable to keep the food down. It's been 2 weeks already in India, but sometimes, just your stomach gets too immune from the Indian pathogens. So yeah, I can't seem to be keeping anything down. So thank you so much for being the fabulous audience that you always are. And I'll see you tomorrow for our advanced file discussion and ready to solve more power-packed questions, learn more nuances, learn more concepts, look at more references, and get into that amazing, amazing learning environment that we create every week. Can't wait to have you all in that bubble. And thank you so much. Have a very, very good night. See you all. Thank you. See you tomorrow. Bye-bye. And please send me messages if you still want to join the crash course. We have a discount going on. So thank you so much. Bye-bye.